All right, guys, welcome back. This is it. Final chapter. You've made it through pharmacology. We're going to cover chapter 16 now, which is some emergency situations that might come up in the OR. And we'll get started here. All right, the first thing we're going to talk about are respiratory emergencies. And we're going to start with allergies and allergic reactions. So allergic reactions in the OR, excuse me, can range from mild to severe. When we're looking at mild reactions, we're seeing probably hives, redness of the skin, maybe some raised patches of skin, usually very treatable mild symptoms. When we're going to severe, we're looking at anaphylaxis, which we will talk about in a bit here. Respiratory symptoms can include bronchospasm, dyspnea, tachypnea, respiratory obstruction, and laryngeal edema. They usually can occur within 2 to 20 minutes, and they can persist for quite a few hours, even a couple of days, as you can see here, up to 36 hours. If early signs appear, triggering meds are obviously discontinued. 100% O2 is administered, fluids are increased, and a dose of epi may sometimes be given, depending on the severity. 2 types of antihistamines are given in surgery to counteract the body's histamine release. And those are classified in surgery as H1 and H2 receptor antagonists. Diphenhydramine, otherwise known as Benadryl, is an over-the-counter. That can be administered IV to treat allergic reactions intra-op. It can be used alone or in combination with H2 if epi and IV fluids alone are not making a difference. Okay. Anaphylaxis. This is a severe and potentially lethal allergic reaction. Complete cardiovascular collapse that occurs rapidly and may include cardiac and respiratory arrest may happen. Usually it does. Under general anesthesia, the first sign of this is going to be some pretty severe hypotension. So we're going to see a pretty significant drop in blood pressure. The most common cause in surgery are the neuromuscular blocking agents, particularly succinylcholine, which we have talked about in the last chapter and we use quite often, but it is a very common allergic reaction trigger. The first line of treatment in surgery is an IV bolus, which means a very fast, full dose of medication. So we're going to give an IV bolus of epinephrine. Okay, hypotension is treated with IV fluids and vasopressor agents like our dopamine and phenylephrine, vasopressin, norepinephrine, and milrinone. And there is a table on table 16.1 on page 222. That does give a good summary of our emergency respiratory drugs. So I would reference that table. Okay, transfusion, otherwise known as hemolytic reactions. These are infrequent, but still an important type of reaction in surgery that is treated and managed by the anesthesia care provider. There are 3 types. First, we have the febrile non-hemolytic. This is caused by antibodies binding to the donor white blood cells. It's rarely seen during surgery, usually characterized by a 1 degree Celsius temperature rise, and it's treated with antipyretics and antihistamine agents. Okay, then we have the allergic reaction to a blood transfusion. These are also usually mild. They're caused by medications that are taken by the donor or additives that are added during the blood and blood product preparation. And they're treated as any mild reaction would be treated with oxygen, IV fluids, and maybe a dose of that Benadryl or epi if needed. Then we have the hemolytic reactions. These occur when A, B, and O incompatible blood or blood products, so our plasma and our platelets, when those are administered. So it's usually characterized by hypotension, hemoglobinuria, which means hemoglobin that's present in the urine, anuria, which is a loss of the ability to urinate, or oliguria. Fever and disseminated intravascular coagulopathy are also present. And we will go over a little bit in class together the disseminated intravascular coagulopathy. You will hear it referred to in surgery as DIC. It is an emergent situation, and it's a little bit scary to experience your first time, so we'll go over that in class together. Control of hypotension and diuretics, such as mannitol, may be used to maintain some kidney function. Right, next we're going to move on to bronchospasm. This is impaired breathing from the constriction and inflammation of the bronchi. A severe bronchospasm could result in injury to the brain or death, so this is an emergent situation. May be triggered by chemical or mechanical irritation. Most commonly, it's tracheal irritation that's caused during intubation. People with COPD, mucosal edema, increased mucus production, and inflammation of the airway are also at risk. The signs include wheezing, prolonged exhalation, decreased breath sounds, decreased O2 sats, which we remember are called desaturations, and we can hear those audible cues from our monitors, increased airway pressures, and again, hypotension, so that drop in blood pressure. The anesthesia care provider will check for mechanical signs such as a blocked ET tube, and then we'll proceed with treatment and diagnosis from there. If diagnosed intraoperatively for a bronchospasm, 100% oxygen is administered and the patient is going to be ventilated manually. Several medications can be used to treat bronchospasm. The B-adrenergic agonists are particularly effective in this. That's going to include albuterol, which you may have heard of. It's kind of a common asthma medication. It is nebulized and then administered via the ET tube. And we also have terbutaline, which is administered by inhalation, or it can be injected subcutaneously. Okay, epinephrine, which is a hormone, may be aerosolized through the ET tube or given subcutaneously to relax smooth muscles. And anticholinergics, are atropine and ipratropium, are aerosolized through the ET tube for patients with COPD. If bronchospasm persists, corticosteroids may also be aerosolized, but those are usually given IV. Another one that we come across relatively often is laryngospasm. This is the involuntary constriction of the vocal cords that can result in a partial or complete closure. It usually occurs during the intubation or shortly after the patient is extubated, especially in the patients that are under a light anesthesia at that extubation. If they're really starting to come to, then this can occur. It is seen more frequently in children and infants, and it's characterized by a very high-pitched kind of crowing sound. We call that stridor with inspiration. It's a very distinct sound. It's significantly increased in infants 0 to 3 months of age and those with asthma or upper respiratory infections. Okay, positive airway pressure is administered by a mask with a chin lift and a partial spasm, but this could make a complete spasm worse. So if it's a partial spasm, we will use this method. However, if it is a complete spasm and they're unresponsive to the positive pressure and the pulse oximeter begins to show those O2 sats sinking more, then succinylcholine is given IV. Small doses will achieve reasonable vocal cord relaxation, and it'll allow for adequate mask ventilation. But if the problem is persisting, larger doses of succinylcholine can be used to relax those vocal cord muscles adequately enough for us to re-intubate the patient, which is sometimes needed. Atropine may be administered in pediatric patients to treat bradycardia and hypoxemia that may come with it as well. All right, we're going to move on now to some cardiac arrest, otherwise known as a code. So this is the sudden, unexpected loss of cardiac function, breathing, and consciousness. It can occur at any time before, during, or after anesthetic. In surgery, we call it a code blue. Now, if a code blue occurs out in the hospital on the floors or in the ERs or anywhere like that, you will hear a code blue called hospital-wide. And that is because they do not have dedicated people there, or there are dedicated people within the hospital. They call it the code team. So they will call that code hospital-wide, code blue, wherever it is, and that code team will respond. Excuse me. In the OR, it is a little different. We are our own code team. So we will call code over the speaker system, but it will stay within the OR. And that will alert just the OR that there is, code blue room 3. And that will alert everyone to grab the code card, and you will be amazed at how many people show up in your room. It usually is anesthesia that makes the diagnosis, calls the code, and initiates the treatment. If no pulse is present, effective chest compressions are initiated immediately by a member of the surgical team. Okay, the anesthesia care provider is going to manage the airway and breathing during the code. Okay, if the operation has not begun, any member of the team may begin compressions. If the operation has begun, the surgeon, the first assist, or the surgical technologist will begin compressions from the sterile field, or the circulator can initiate them from under the drapes. Okay, the effectiveness of our compressions is going to be monitored by capnography. If you remember from our last chapter, that is the end-tidal CO2 that is measured and monitored on our screen, there by anesthesia. Okay, the anesthesia care provider or the circulator is going to administer vasopressors, antiarrhythmic drugs as needed. A designated team member will go for the crash cart containing the defibrillator. And several factors are going to influence the role of the surgical tech during a code. Several things. If you're scrubbed, if you're not. There's a lot of questions that can be asked. Did the arrest occur before general anesthesia? Then you can break, scrub, and help. Did it occur after incision's been made? You may be required to stay scrubbed and protect your sterile field, or get the incision closed quickly so that we can continue to work the code. Did the arrest occur during the regularly scheduled day? More personnel are usually available to help out so you can protect your sterile field and stay scrubbed in. If it's an on-call situation, you may be the only ones there and you're going to need to break, scrub, and help. So it's very, very case specific as to what our role in the call of a code is. And we will have regular in-services and regular meetings with your facilities about what codes are, what their roles are, what everybody's job is in that situation. Okay, so the first line of treatment is epi. That's a hormone that acts as a vasopressor and an inotrope, which we will go over in a bit, to strengthen the force and the rate of our myocardial contractions. So they're going to really strengthen how our heart is beating. Okay, vasopressin is another first-line drug. It causes intense peripheral vasoconstriction to support that blood flow. Okay, so we're going to really constrict those vessels and raise that blood pressure. Okay, certain cardiac arrhythmias may lead to cardiac arrest, and they're treated accordingly. Bradycardia may be treated with epi, atropine, or dopamine, and tachycardia may be treated with various agents, kind of depending on the type. And there was an interesting spot that I want to bring up. It does not happen very often. However, if IV access is not established, or additional lines maybe are needed, and we've had a circulatory collapse where we just can't get any kind of a central line or another IV or an ART line, we can't get any kind of an IV access, then there is something that can be done called IO access, and that is intraosseous. So if we break that apart, that means in the bone. So when that happens, a battery-operated drill with a specialized needle and cannula combination is used to drill through the cortex of a long bone, so the femur or the humerus, any long bone, to access the bone marrow. the drill and needle are going to be removed, leaving that cannula in place, and standard infusion tubing then for our IV is going to be connected to the cannula and deliver fluids and medications that way. And it can be left in place for about 24 hours. The reason that we do this is because bone marrow is incredibly efficient at diffusing medications and blood. It's very vascular and it's very, very efficient at getting those things out to the body and where they need to go. So very rare, but in an extreme situation, that is absolutely a possibility. Okay, we're going to go through just a few miscellaneous cardiovascular drugs. There's tons of them. We're just going to go through the most common ones. Okay, so first we have the adrenergic agents. These are agents that mimic the effects of epinephrine and norepinephrine. So our dopamine increases the blood pressure and cardiac output, so it might be given to treat bradycardia. Then we have dobutamine, which is used to treat cardiac failure and hypotension. Isoproterenol hydrochloride is used to increase the rate and force of myocardial contractions, so we're obviously going to use that to treat bradyarrhythmias, which are slow rhythms, and it's going to serve as a bronchodilator as well. Okay, we have norepinephrine, which is used to raise blood pressure, and albuterol, which we talked about a little bit earlier, is used to treat bronchospasms. Those are our adrenergics. Okay, then we have adrenergic antagonists. These are agents that block the effects of epinephrine and norepinephrine. So atenolol, metoprolol, and labetalol are used to slow heart rate. They can also be classified as class 2 antiarrhythmic drugs. They're used to treat tachyarrhythmias and hypertension, and we will go through what class antiarrhythmic drugs are in just a minute here. Okay, then we have the cholinergic agonists and antagonists. Agonists are going to mimic the effects of acetylcholine. They are not used in the treatment of cardiac conditions, and they do include pilocarpine and neostigmine. We're simply just listed here for a comparison value. Antagonists are going to block the effects of acetylcholine. So atropine sulfate is going to block the effects of the vagus nerve on that SA node in the heart. So it's used to treat bradycardia when needed. It's given pre-op to dry oral secretions, and then it does have systemic effects. All right, our antiarrhythmic agents. There's 4 classes of these. Class 1 are sodium channel blockers. These include the procainamide and lidocaine. We're used to treat VFib and VTAC, but they have been replaced since then by amiodarone, which we use quite often. And that's a class 3. Okay, class 2, these are our B blockers. Atenolol and metoprolol are used to treat tachyarrhythmias. Class 3 are our potassium channel blockers. The most common of those, as we said, is amiodarone. And then we have class 4. These are also calcium channel blockers. They include the dilatium and verapamil. They reduce the flow of calcium into the heart and blood vessels, which results in vasodilation, which is what we hope to accomplish when giving these. There is another drug, adenosine. It is also an antiarrhythmic agent. However, it is not classified into any of those 4 classes, and that's because it's a naturally occurring nucleotide. And it's used in the diagnosing and the treatment of SVT. Okay, next we have our vasodilators. These are agents that relax the smooth muscle cells in the blood vessel walls. So they reduce our blood pressure and they enhance blood flow to those vital tissues. Nitroglycerin and nitroprusside are vasodilators that are used to treat angina, acute myocardial infarction, and congestive heart failure. Okay, nicardipine and nifedipine are calcium channel blockers and arterial vasodilators. Those are used to treat stable angina and some types of tachycardia. The one that I want you guys to really take away from here is this nitroprusside. That one and nitroglycerin are two that we use quite often in surgery, so those are the two I'd like you to know from there. Okay, our inotropes and our vasopressors. These are administered to increase blood pressure. Inotropic agents increase the force of cardiac contraction, the cardiac muscle contraction, which in turn increases our BP. Obviously, if our heart is beating harder and faster, so our blood pressure is going to rise. And that agent that we talked about just a few minutes ago is dobutamine. Okay. Vasopressors cause vasoconstriction, which increases blood pressure as well. As our vessels constrict, the force of that blood against the walls is going to get greater. Our blood pressure is going to rise. And those two drugs are phenylephrine and norepinephrine. Okay, there are two other ones, dromotropic agents. They increase the conductivity of the cardiac nerves and muscle fibers. And chronotropic agents influence the rate of cardiac contractions. All right, and finally, the last emergent situation that we are going to cover is malignant hypothermia. I'm going to do a very brief review of this because I know we have discussed it a few times before in the past. So the administration of succinylcholine in combination with those volatile inhalation agents, so remember all of our ANEs, suflane or suprane, desoflurane, all of our ANEs are triggering agents. They're thought to speed the onset of this condition and kind of increase really the magnitude of its signs. One of the first things that we're going to look for, remember, is a significant rise in the patient temperature. Another early sign is an increase in our end-tidal CO2. Remember, our carbon dioxide is going to go up. Tachycardia and muscle rigidity. Those are our good indicators that we may have an MH crisis on our hands. Okay, another couple of signs and symptoms we can look for would be unstable blood pressure, arrhythmias, cyanosis, so they're going to kind of start getting that blue tint to them because they're not breathing properly, diaphoresis, which is profuse sweating, excuse me, and pyrexia is another one that we might see. Some of the later stages of MH, if we're getting a little, deeper into the crisis, you may see some skin mottling, myoglobinuria, which is kind of a colon or a cola-colored urine, and hyperkalemia, which we know is a rise in our potassium levels. All right, so once MH has been identified, the surgical procedure is stopped. Because we are going to go all hands on deck to get this crisis covered and this patient cooled off. An MH crisis can escalate quickly enough that the patient we may see a death within 15 minutes. So it is all hands on deck to get this crisis under control as quickly as possible. Okay, all triggering agents are discontinued. That's our succinylcholine and our inhalation agents. The patient is going to be hyperventilated with 100% oxygen. Dantrolene, which we remember is a skeletal muscle relaxant, is going to be administered IV. The initial dose of dantrolene is 2.5 milligrams per kilogram. The vials are reconstituted, remember, with 60 milliliters of sterile water. And just to kind of give an idea of the amount of medication that it takes, in an adult patient weighing 80 kilograms, so about 176 pounds, 200 milligrams of dantrolene is going to be required for that to begin treatment. That is 10 vials of dantrolene. Okay. If no help is available, say it's after hours, it's a weekend, or everybody is in rooms, there's no extra staff, it may be absolutely necessary for the surgical technologist to break scrub and assist in the reconstituting of that dantrolene. It is not easy to mix back up. Once that sterile water is in, we need to shake that vial vigorously until it becomes a clear yellow color. And it really is not an easy thing to do. Okay, that dosage then can be given about every 5 minutes until anesthesia instructs us otherwise. Now there are 2 boxes that I do want you guys to review. That is 16.3 and 16.4 on 228 and 229. Those list the medications that we use to treat MH, and it also lists the treatment steps that we are going to use in an MH crisis. So review those boxes, guys. But other than that, that's it. You did it. You've survived pharmacology. Any questions on this chapter, leave them here, and I will see you guys in class in just a little bit.